So what are the surgical treatment options? All right, there's been an evolution over time. We've shied away from malabsorptive procedures and we've gone more and more towards restrictive procedures. Back in the day, for example, the jejunal bypass, the biliopancreatic diversion were popular procedures that were done. However, patients had very poor outcomes in terms of their nutritional status. A lot of them developed a lot of electrolyte abnormalities that eventually died. The vertical banded gastroplasty then got kind of popular, which is basically 5 row staples along the upper part of the stomach and create a restrictive band below. So when food came down the esophagus, this compartment would stretch and give the patient a feeling of fullness, and eventually the food made its way down. However, what was noted was the staple line here, this part of the stomach where it was stapled would actually reconnect, and patients regained all of their weight. So we're seeing a lot of failures of the vertical banded gastroplasty, and we're having to convert them to other procedures like the Roux-en-Y gastric bypass. But the most popular and most accepted procedures as of today is the gastric bypass, the lap band system, the sleeve gastrectomy, and the duodenal switch. And I will go over all 4 procedures in detail in a little bit here. Let's start off with the Roux-en-Y gastric bypass. What exactly are we doing here? What exactly is the Roux-en-Y gastric bypass? It's considered the gold standard because it's been around for at least 50 years, and we have 50 years of experience with how to manage these patients, and we also looked at outcomes in terms of long-term weight loss, etc., and this is considered the gold standard. Basically, with the gastric bypass, what we do is we divide the stomach all the way up top, so they end up with a small 30 cc pouch. Okay. So when food comes down the esophagus, it fills up this little pouch, and then it stretches and it sends reflexes back to the brain saying that they're full. Okay, and then the patients stop eating. Now, to maintain continuity of the flow of food, what we do is we divide the intestine further down, and we bring the lower part of the limb, and we attach it to the new stomach pouch. So food then eventually enters this pouch, gives them that feeling of fullness that eventually makes its way down this part of the limb. Now, the old stomach kind of just sits there, does its thing, produces acids or whatever is required, and the biliopancreatic limb is still connected to the pancreas and the bile ducts, so all these enzymes are released in here that eventually come down this way and meet up with the food bolus, and this is where all the mixing occurs, and then you have plenty of small intestine for absorption to take place. So how do patients lose weight with this procedure? Basically, you're creating a restriction, so you're restricting the amount of, or the caloric intake, by giving them the sensation of fullness with smaller quantities. Okay, so that's one way, is restriction. The other way is when we divide the stomach, as soon as we divide the stomach, there's endocrine changes that occur within the body that enable rapid weight loss. There's also a hormone called ghrelin, G-H-R-E-L-I-N, that is known as a hunger hormone that increases your food intake, increases your hunger basically, decreases your metabolic rate, and decreases your breakdown of fat. This is not a hormone that you want high levels of. With this procedure, as soon as you divide the stomach, we're seeing a complete flat line of ghrelin levels, low levels of ghrelin, basically taking the hunger away. So here's an animation of this procedure so that you understand exactly what we do. Right? This is all done laparoscopically with tiny little incisions. And then we put a camera through one of the trocars, we put instrumentation through the other trocars, then we go in, and then we divide the stomach. Okay, and we make sure it's completely divided. Then we go further down, we divide the small intestine, and we bring the lower part of the intestine and attach it to the new pouch, and then the old stomach, along with a short segment of small intestines, is reattached further down. This length from here to here is typically about 100 centimeters. And this biliopancreatic limb length is about 50 centimeters. And then you have hundreds of centimeters of small intestine for absorption to take place, therefore avoiding complications of malabsorption. The lap band is another procedure that's been around now for about 15 years. It's basically a silicone device that's placed around the upper portion of the stomach. It's placed in such at a level where you essentially end up with a 30cc pouch. So same concept. When food comes down, this little pouch fills up. The pouch stretches and it sends reflexes back to the brain saying that they're full. And eventually the food trickles through this little tight opening into the stomach and the rest of the intestines where there's no anatomical changes. Okay. Now this band is an adjustable band. On the inside of this band is a balloon that can be inflated and deflated. That balloon is then attached to this tubing that sort of floats around inside the abdomen, which is then connected to a port that's placed deep to the skin right above the anterior rectus sheath or fascia underneath the subcutaneous fat. It's fixed there so that we can access it for possible adjustments. And we're talking about adjustments. If a patient comes in and tells me, Dr. Bobby, I cannot keep anything down, everything I eat comes right back up. So what I do is then I take a Huber type needle. It's a non-coring Huber type needle. Then I access the port just like you would access a Metaport, and I would inject some fluid that eventually fills up this balloon on the inside, which then tightens. And if they're complaining of vomiting, I would actually release the fluid from this balloon. So I stick a Huber needle into this port and I would suck some fluid out, and that releases some of the restriction. Now, if a patient comes in and complains about not losing any weight and basically having no restriction, I would access the port again just like you would a Metaport with a Huber needle and inject some fluid to tighten up this balloon, to inflate the balloon, which then tightens up the opening. Okay, let's look at the animation. There's a procedure that's also done laparoscopically, and it's placed around the upper portion of the stomach. Okay, and so what you end up with is a small 30cc pouch. Notice the orientation of the band. It's from a 2 to 7 o'clock position. Okay, that's the orientation that you would also see on X-rays, and that's a normal orientation. When that orientation changes, for example, if this band was sitting this way on X-ray, that means the stomach has slipped through the band. So one of the complications we see with the lap band is that stomach can slip or herniate through the band, causing an obstruction. The other complication that we also see with the lap band is erosion. This being a foreign material, the body can sometimes reject it or incorporate it into the stomach. We call that erosion. Okay. So again, the band is doing the same thing as the bypass, except that you don't get any hormonal or endocrine changes with the lap band. So here's an example of how we do a band adjustment. Basically access the port, inject fluid to then inflate the balloon inside the band, which then creates a restriction. So now you'll notice that this fills up a lot faster, creating the restriction. Patients will typically need about 5 to 6 adjustments a year, an adjustment every couple of months, in order to find that sweet spot, the sweet spot where they are feeling just the right amount of restriction and not having any reflux or vomiting. Okay. The newer procedure now that's gained a lot of popularity over the last 5 years is the sleeve gastrectomy. This is a procedure that most insurance companies have now accepted as a bariatric procedure and are actually authorizing it. So basically what we do here is we divide the stomach longitudinally, okay? And this greater part of the stomach is essentially then removed from the patient. So they end up with this little banana-shaped stomach. So you're not really altering the anatomy much, just like the lap band. All you're doing is you're just taking away this greater curvature of the stomach. You end up with a little banana-shaped stomach. This ends up being more forgiving of an operation in terms of malabsorptive issues. And the only vitamin that we typically worry about with this procedure is vitamin B12. Most of the other vitamins are pretty well absorbed because the rest of the anatomy here remains the same as before. So this is sleeve gastrectomy. This is an animation of the sleeve gastrectomy. Again, this is also done laparoscopically with tiny incisions. Procedure is can be a same-day procedure where we typically keep these patients overnight, sort of like the lap band. However, we just see significantly more weight loss with the sleeve gastrectomy. Now, the same slide is actually going to transition into the duodenal switch. Okay, what exactly do we do with the duodenal switch? Basically, we divide the stomach just like a sleeve gastrectomy. Okay, actually, let me go back to that other slide here. I'm sorry. Okay, how do patients lose weight with this procedure? This procedure will also create a restriction because the stomach is a lot smaller than it was before. And we typically use a size 36 bougie to size this pouch, which is kind of the average size bougie that most surgeons use. And as soon as we divide the stomach, just like the gastric bypass, what happens is there's essentially a drop in ghrelin levels, therefore taking the hunger hormone completely away. And you also have restrictions. So it's kind of like the bypass. It's creating a restriction, so you're losing weight by restriction, and you're also losing weight by these endocrine changes that occur as a result of dividing the stomach. Okay, so the duodenal switch is sort of similar, where we divide the stomach. In addition to that, we also divide right beyond the pylorus here, and we bring this loop of bowel from below and we attach it to the duodenum. So unfortunately what happens is the way they did, this is one of the traditional types of duodenal switches. Basically there's a very short segment of common channel where you have both the enzymes and the food that mix together and enable absorption to take place. So this could potentially result in significant malabsorptive issues. Now there's a modified duodenal switch, which is more ideal in order to avoid all these malabsorptive issues, and that is where we essentially take away the greater curvature of the stomach, just like a sleeve. In addition to that, we divide right beyond the pylorus. Then we measure about 250 centimeters backwards, all the way up 250 centimeters, and we bring that part of the bowel as a loop, and we attach it in an end-to-side fashion to the duodenum. So basically, food comes down and goes down its normal path down the common channel here. The biliopancreatic limb, which essentially was divided here, the duodenum was divided here. All the enzymes come down this part of the bowel, kind of come down this way, all the way up, and this is where all the mixing occurs and kind of takes the normal peristalsis all the way down. Okay, so the good thing about the modified duodenal switch is that you have about 250 centimeters of intestine for absorption to take place, which is more than what you have with the traditional duodenal switches. So this is gaining more and more popularity as well. The intragastric dual balloon has recently received FDA approval. It's basically a balloon that occupies space within the stomach and creates a sense of fullness. And however, this is a temporary procedure, and it requires removal in about 6 months. With this, they've seen about 6.2 to 3.3% of total body weight loss, which is really not significant. I envision this being a way to, as a transition, as a step one procedure for patients that are significantly overweight, and by that I mean over 500 pounds. We typically want these patients under 500 pounds for safer surgery, and we can still do it laparoscopically with smaller incisions. So this could be a good transitional type of a procedure, sort of getting prepared for the actual Roux-en-Y or sleeve or duodenal switch. So that's out. It's also apparently for the lighter weight patients that just want to lose weight. However, I'm not sure how ideal it is, because these patients do present with a significant amount of nausea and vomiting after surgery. So what type of weight loss do we see with these procedures? With the lap band, it's about 50%. Patients can lose up to 50% of their excess body weight. With the sleeve gastrectomy, it's about 60 to 70%. With the gastric bypass, it's about 70 to 80%. With the duodenal switch, it's about 80 to 90%. With the modified duodenal switch, is also about 80 to 90%. So you can see why patients prefer going with a switch as opposed to some of these other procedures. But you know, the sleeve gastrectomy and the gastric bypass are pretty close to what close in terms of the percentage of weight loss. And again, you know, with these are just averages. There are patients that will lose 100% of their excess weight with any of these procedures. It all depends on their compliance factor. Okay. Weight loss after surgery, in the first 6 months, we typically see about a 50% weight loss, 50% of their excess body weight. So if they have about 100 pounds to lose, they will lose about 50 pounds in the first 6 months, and they'll proceed to lose the rest of their excess weight over the next year or so. So in the first 6 months is their golden period. It's also the month where we watch them very closely for complications. So I want to remind you that the medical outcomes of bariatric surgery. I mean, type 2 diabetes, imagine getting rid of that. Hypertension, imagine getting rid of that. Sleep apnea, hyperlipidemia. These are major medical issues that can be resolved with these procedures. Now, the question is, how much weight will surgery by itself help these patients lose? It's kind of a trick question. Answer is 0. And this is what we drill into all of our patients' minds, is that surgery alone by itself is not going to do anything for them. They have to still eat right and exercise. Now, Courtney, who's been a dietitian, she's a bariatric dietitian. She's got a master's degree in dietetics and specializes in bariatric dietetics. Will come and introduce you to some of the dietary aspects of bariatric surgery patients that you might want to just briefly know.
Hello, my name is Courtney Markey. I am the bariatric dietitian for Dr. Bobby Bhaskar-Rao. I will be talking about the nutrition aspect of bariatric surgery. So, unfortunately, surgery isn't just the magic solution to obesity. patients do need to take the time to learn how to eat right and exercise in order to keep the weight off. So typical dietary guidelines after bariatric surgery is a dietary progression through different stages of the diet. Right after surgery, the first day while they are still in the hospital, patients are on a clear liquid diet. This is chicken broth, sugar-free Jell-O, sugar-free popsicles, water, decaf tea, and decaffeinated coffee. Patients are given a little, kind of like a Dayquil cup, 30 cc's worth or 1 ounce cup, and they just take a drink every 15 minutes. It helps them learn what that new feeling of their stomach is instead of just rushing into eating and drinking right away. When patients go home from the hospital, they are on a full liquid diet. Full liquids are still things that they do not need their teeth for, but they do not need to be clear. So patients can start incorporating protein shakes. Protein is very important after surgery. It helps prevent lean body mass loss. So we want them to lose the fat and not the muscle. So we encourage protein shakes right after surgery. Other things that they can have on a full liquid diet would be yogurt. I always suggest a Greek yogurt rather than regular because it has a higher protein content, and then they do have to make sure the sugar level in the yogurt is low. They could also have a very thin cream of wheat as well, or they could start drinking milk or soy milk. After about 2 weeks, they come back to our office and are progressed to the next stage, which is just pureed foods. So kind of baby food consistency, but I let them know as long as they can smash the food very well with a fork before they eat it, then it's fine and safe for them to eat. They're still concentrating on getting high proteins. 60 to 80 grams of protein is what is recommended each day. And they need to just do small quantities of food at a time. So if they went home and ate a full meal, that would definitely hurt their stomach. They would be in pain for a while. They need to focus on just eating the very small quantities of food, feeling what that new feeling of fullness is for their stomach, and then stopping once they get that feeling. Meals need to last at least 20 minutes or more. It takes our stomach about 20 minutes to tell us that we are full. So if patients can eat a whole meal in 10 minutes, then they could have easily overeaten and not ever received that signal that they are full and need to stop. By overeating, then again, that leads to a stomach ache, which is very uncomfortable for patients after that bariatric surgery. Like I mentioned before, high protein foods should be eaten at all meals. I suggest to our patients that they eat high protein foods first. So if there is chicken and broccoli and mashed potatoes on the plate, then they should definitely eat the chicken first. Go for the broccoli next to add fiber in their diet, and then only if there's room do the mashed potatoes. It would only be maybe 1 or 2 bites. Usually there's not room after they've had the protein, especially if it's been sooner since they've had the surgery. Like I mentioned, to avoid protein malnutrition, patients need at least 60 grams of protein a day, but I really push for closer to 80 grams. While they're in the hospital, they're on the clear liquid diet and they're not getting that protein they need. So once they get home, we want to get them home and back on to the protein as soon as possible. Certain foods give different patients certain foods are not tolerated by certain people. So things that are dry, such as roast beef or turkey, can be very hard for patients to digest. I always tell them to add some broth or some low-fat gravy in order to help the food slide down. Other foods that are very sticky, like peanut butter, can be hard for the stomach to digest as well. Because think about it, it's about the size of a golf ball after the gastric bypass. So that chunk of peanut butter doesn't move through very easily. Gummy foods such as fresh bread or white sticky rice are hard to digest as well, I suggest that patients avoid those foods for at least the first 3 months to give their stomach enough time to heal and get used to that new feeling. Finally, things that are stringy or fibrous, such as celery or especially salad. A lot of patients cannot tolerate salad for the first 6 months. If it's something that they don't tolerate but they really like, I always suggest that they try it again in 3 months, because sometimes the stomach is able to handle new foods after just a little bit more healing time and time to adjust to the new body and new weight. Patients also need to commit to a patients need to also commit to taking vitamins for the rest of their lives. Nutrient deficiencies can occur, such as iron, B12, calcium, folic acid, and thiamine. These nutrients are absorbed in the duodenum, which is the first part of the small intestine directly after the stomach. For the gastric bypass, that first part of the intestine is bypassed, so those nutrients are less absorbed. With B12, it is actually activated in the stomach by an enzyme called intrinsic factor. When we remove most of the stomach, such as in the gastric bypass or the sleeve gastrectomy, that intrinsic factor enzyme is reduced, which then reduces the activation of B12. Hydration is also very important after surgery. When the stomach is much smaller, patients need to think about drinking water all throughout the day instead of waiting until they're thirsty. If you or I went to drink a bottle of water, we could chug it down, no problem, and feel fine. Patients after bariatric surgery, if they tried to do that, they would just end up with a huge stomach ache because there's not enough room in the stomach, or the water would just regurgitate back up. So I teach patients to monitor how much water they drink, measure it each day, and keep a pretty close estimation so they get that 8 glasses or the 64 ounces each day. Patients also need to exercise. I suggest just 30 minutes of anything a day. Doesn't matter what they do. We'd love them to do a lot of different things, but we have to think about they've been obese and sick and in pain for a very long time. So they can't just start running marathons. It takes them time to work up to it. So 30 minutes of anything is what we suggest in the beginning. So chewing gum, you could burn 11 calories an hour. We suggest to our patients to not chew gum right after surgery, because if they were to swallow it, we don't want them to end up with an obstruction. But walking at a very slow pace, they can burn about 200 calories. So it just helps them kind of get moving and prevent any blood clots or pulmonary embolisms. Bicycling is also great. Once patients lose a lot of weight, though, they tend to feel less balanced. Their center of gravity is in a different area. So I suggest maybe going to a yoga class first before they try to get back on the bicycle. Gardening, also a great chore. Again, it doesn't matter what they do as long as they're being active for that at least 30 minutes. On here, though, this graph is showing how many calories you burn per hour. So sexual intercourse is on there, 500 calories, but it has to last a whole hour. But running, once they've built up to it, they could run at a faster pace and burn quite a lot of calories. I just show this graph to all of our patients so they get an idea that, just walking or doing something moving is going to burn the calories. It's going to help reduce the diabetes by making their making their insulin work better in their body, and just help with the maintenance of weight loss after they have started to lose the weight. I'm also going to talk about ghrelin, the hunger hormone. I call it the little gremlin that's growling in the stomach. So it's made by the stomach. It increases your want for food, and it also decreases how much calories and how much fat our body burns. This graph shows ghrelin levels The bottom line there is a normal person's ghrelin levels. So it increases around breakfast time. After they've eaten breakfast, ghrelin levels decrease, spikes again around lunch, and then again around dinner. The reason that diets do not work for a lot of our patients is because ghrelin kind of works against us when we're on a diet. That top line there is ghrelin levels when somebody is on a diet. Notice that the ghrelin levels spike much higher during meal times and are just in general higher throughout the day. So that person who is on a diet, their metabolism is lower, their breakdown of fat is slow, and they are hungrier. The awesome thing about the gastric bypass surgery in particular is that bottom line there. Once we remove the stomach, it does not produce that ghrelin hormone anymore, so the ghrelin levels have flatlined. I have patients that tell me they forget to eat because they don't have that hunger hormone anymore. They have to actually set an alarm or download a bariatric timer to tell them when to eat so that they remember. So I hope I've explained a lot of the nutrition aspect of bariatric surgery. Dr. Bobby's going to come and finish for the complications.